Right. Well, I will introduce our next abstract. So we have multiple presenters on this next abstract, Hanna Attasseril, Danielle Brister, and Caroline Adkins from Arizona State University's College of Health Solutions and the School of Human Evolution and Social Change. They'll be presenting, or the title of their presentation is COVID-19 related stressors experienced by linguistically and ethnically diverse women during pregnancy, birth, and postpartum periods.
Good morning, everyone. I'm Caroline Adkins, and I will be presenting with my other two undergraduate student co-authors, Hanna Attasseril and Danielle Brister, and we will be discussing COVID-19 related stressors experienced by linguistically and ethnically diverse women during pregnancy, birth, and postpartum periods. Early in the pandemic, it became clear that pregnant women were at higher risk for severe COVID-19 outcomes compared to non-pregnant women. Pregnant women were at greater risk of needing a ventilator, as well as delivering a preterm or stillborn infant, and were at higher risk of death. We also know that pregnancy itself introduces many stressors to a woman's life, and women are at risk for postpartum depression due to changes in hormones following birth. Given the increase in stressors due to COVID-19 and decrease in typical social support and coping mechanisms, there was concern for psychosocial well-being of postpartum women during the pandemic. Emergent data from a universal testing strategy at Valleywise Health, Labor and Delivery in the early summer of 2020 identified that ethnically and linguistically marginalized groups, specifically resettled refugee women, experience COVID-19 infection at higher rates compared to a diverse population of patients served during this time. From the plenary talk this morning by Dr. Crista Johnson-Agbakwu, we know that these marginalized groups are deeply affected by the social determinants of health, or non-medical factors such as housing, education, and food availability, and experience additional structural barriers to access and uptake of quality healthcare typically. Disparities caused by these factors were exacerbated by the COVID-19 pandemic. Therefore, our objective was to understand the lived experiences of an ethnically and linguistically diverse sample of mothers who gave birth during the COVID-19 pandemic. Individuals were sampled from language-specific randomized lists by language group at the hospital, seeking to overrepresent refugee populations who, although make up a smaller proportion than Spanish or English-speaking patients, were contracting COVID at highest rates early in the pandemic. For the inclusion criteria, the sample were women who gave birth between May and December of 2020 pre-vaccination, and telephone interviews were conducted between March and June of 2021. We used inductive and deductive approaches to create codes based on what we saw in the data, such as prevention measures and coping strategies, and those we anticipated would be present, such as the fear of contracting COVID. 4 of us read the open-ended questions and created the codebook together. And here on the slide, you can see an example of one of our codes. For the demographics, there were 11 to 18 individuals per each of the groups of resettled refugees who participated, with larger sample sizes of English and Spanish speakers. On average, women in each group were around 30 years of age. I will now turn it over to my colleague, Danielle Brister, to move into the thematic results.
While we will not present and focus on all of our themes quantitatively, we do want to share how universal some of these themes are. The first is the single most common stressor, the mother's fear of contracting COVID-19 for herself and her baby. It emerged in all linguistic groups and in 50% or more participants from all groups, except from those speaking Kinyarwanda or Swahili. Certain concerns that were most prevalent included mothers worrying about becoming infected with COVID-19 and then infecting their baby during and after pregnancy, and worrying about whether or not the baby would survive if infected. Women responded to this by implementing certain measures that they most confidently felt would protect themselves and their baby. Specifically, the fear of COVID-19 stressor led women to strictly follow COVID-19 prevention measures. The strict adherence to COVID-19 prevention measures was mentioned by a majority of participants in all groups except Kinyarwanda, which was close. This adherence manifested by social distancing, sanitary practices, mask wearing, and vaccination affected women's lives by diminishing the enjoyment of preparing for a baby, by increasing stress and anxiety, worrying about the cleanliness of surroundings, and by increasing feelings of personal detachment from the child. Implementing the prevention measures just mentioned resulted in feelings of social isolation for some and extensive coping mechanisms for others. The themes of social isolation and coping mechanisms were overall less frequent than the others. The themes of social isolation came out among a minority of participants in the Arabic, Spanish, and English speakers only. Feelings of social isolation were typified by mothers not being able to be with their baby when they wanted to, mothers feeling that socialization was very difficult, and that life was boring and lonely. In terms of coping strategies, this theme came out among a minority of participants in the Kinyarwanda, Spanish, English, and Arabic speakers only. Coping strategies included turning to religion, hobbies, support systems, and family members, as well as strategies that participants identified as not healthful in the long run, such as binge eating and overeating. I will now turn it over to my colleague, Hanna Attasseril.
I'll be continuing with other challenges to care and additional stressors. So difficulties finding childcare was another challenge that presented a barrier to care. This was common in the Spanish, English, and Arabic speaking groups. Additionally, just as Danielle mentioned that the fear of COVID infection was a pretty common fear across all the language groups, this also tied into concerns about childcare, as participants worried if their child or if their usual caretakers were sick, then it would be more difficult to find childcare. Additionally, there were some concerns about the quality of childcare given the limited options available. Finally, these last two factors were only seen in low frequency in the Spanish-speaking groups. So there was a few instances where the support person, usually the spouse or partner, was taking care of other children, which made them unable to attend the appointments and delivery. And there was also a few cases where participants reported missing appointments or reducing the frequency of appointments due to the inability to find childcare. Although these last two were in much lower frequency, they still represent important barriers to care. In regards to quality of care, about 60% of participants felt their care was the same, 25% of participants felt that care was better, and 15% of participants felt that care was worse compared with before the pandemic. So here we have an example of a participant from one of the refugee groups, and she said the care is the same, no changes at all. This may be partially due to the fact that care for the refugee groups was mediated by cultural health navigators, and this helped to provide some consistency despite changes to having less face-to-face and fewer postpartum appointments. And this sentiment was expressed in a majority of participants in the refugee groups. There were also some instances of participants in other language groups feeling that their care was about the same as before the pandemic. Again, there were some participants who felt their care was actually better than before the pandemic, and factors that contributed to this included more attentive healthcare staff, participants feeling that they were treated well, and some participants felt safer with the increased precautions and COVID policies, which helped to alleviate some of those fears around COVID infection. In this example, the participant stated that the nurses were very careful, everything was sanitized, that made me feel comfortable in the hospital. Finally, there were some participants who did feel that their care was worse compared with before the pandemic. The distribution of rankings was pretty similar across the language groups, with the exception of the Spanish-speaking language groups, which had the highest proportion of poor ratings. Some factors that contributed to feeling that care was worse included less attention from healthcare staff, which included shorter appointments, feeling busy with COVID cases, or where the participants perceived that their healthcare providers were afraid of getting infected. Additionally, there were some concerns about supplies and availability of care due to the impact of COVID. So this participant felt that her care was worse because there weren't enough staff compared to before, and you could tell the nurses were always afraid. Everyone knew that there were greater emergencies to attend to. Finally, there were a few additional stressors. The themes of financial insecurity, concerns about the mental health of children, and familial concerns were most prevalent in the Spanish-speaking group, while workplace stressors were in higher frequency in the English-speaking group. In conclusion, postpartum women across linguistic groups experienced a variety of increased stressors directly attributable to the COVID-19 pandemic. Coping strategies and feeling good about quality of care helped some women to manage their concerns. And finally, culturally tailored interventions to support psychosocial well-being of postpartum women would be an important step towards reducing health disparities. We greatly appreciate the time that our participants shared with us as new mamas, in addition to our enumerator team. Finally, we would also like to thank Watts College COVID-19 seed funding and Southwest Interdisciplinary Research Center for facilitating our funding. Thank you.
Thank you so much, Hannah, Danielle, and Caroline. That was a really great talk. Some really important work that you did. If there are any questions, please feel free to type them in the chat. While we're waiting, I'll ask a question. So as the pandemic has evolved and we're maybe in a state where things seem better, but may get worse again. Now with vaccinations being more prevalent, do you think that you would find the same things that you found in your current work?
I think there might be a few changes, especially because the biggest fear that we came across was that fear of COVID infection. So maybe there would be some changes to that. At the time that we interviewed the participants, the vaccines were not available. So it would definitely be interesting to do further research there.
I have a question. You presented on, and thank you for a great presentation. These are my students, so full disclosure to the other attendees. I'm curious, we presented on broad results. What might you be able to say about particular groups? Was that part of your analysis in terms of findings being different between groups?
I think we focused on this study on identifying themes that were more universal. So that's why we presented them on the ones that are more frequent in most of the populations. We did do a little bit of relative comparisons. So those were the populations that we mentioned where some themes were a little bit more prevalent, but hopefully in the future, we'll be able to do a more detailed quantitative analysis of those themes.
Additionally, I feel like some language groups, such as the Spanish group, was more explained, were more elaborative in their responses, and that really helped with thematic analysis.
Looks like we have a couple of questions in the chat, so I'll read those to you ladies. Kate Dobler asks, did the status availability of care prior to COVID come into discussion at all when looking at the findings of care being the same?
I might actually take the chance to direct that to Frida Espinosa, who will be giving a second presentation shortly.
Perfect. And then the other question is, did you find any barriers to patients wanting to share their experiences or fill out the surveys?
Yeah, I think initially some of the recruitment was a little bit difficult at the beginning. If I remember correctly, I think the cultural health navigators, when they were doing the surveys, they tended to have a little bit better of a time with the recruitment because there was already an established relationship. And with the other participants, some of them, like as we kept going through the survey, they would start to open up a little bit more. And like Caroline mentioned, some of the participants had more elaborative responses versus some of them would kind of answer more just exactly what the question was asking.
I would also add that we had really high recruitment among the refugee groups because we engaged the cultural navigators who have built a relationship over the years with the community and with these women individually. And I think fairly good recruitment in Spanish. Again, Frida will be giving a presentation where she might talk about why that was successful. And I think our recruitment was maybe porous through English language, where we had a broader, I think maybe 1 in 4 probably participated.
Well, thank you so much, Hannah, Danielle, and Caroline, for that great talk. Really amazing work that you all have been engaged in.